an often underestimated burden of viral hepatitis. The World Health Organization's Global Hepatitis Report 2024 revealed that India has over 11% of the global hepatitis burden, with 35.3 million cases in 2022. Hepatitis C is a major contributor to this burden, with an estimated 5.5 million people living with chronic hepatitis C infection. The disease is a silent killer, often progressing without symptoms until it has caused significant liver damage, leading to cirrhosis and liver cancer. Now, despite the availability of a highly effective and a curative direct-acting antiviral medicines, diagnosis and treatment coverage in India remain low, with only about 28% of the cases being diagnosed and only 21% of those diagnosed receiving treatment. So similarly, for hepatocellular carcinoma, a primary liver cancer, poses a growing global burden. Its incidence is increasing, especially in developed countries. Risk factors for chronic liver disease and subsequent HCC are shifting, with non-alcoholic fatty liver disease and non-alcoholic steatohepatitis becoming increasingly important causes concurrent with rising obesity and metabolic syndrome. The challenges in the hepatocellular carcinoma often becomes that it's symptomatic only at a later stage. And early stage HCC is asymptomatic, making screening and diagnosis particularly challenging. So even after receiving a sustained virological response with curative treatment, patients with pre-existing advanced fibrosis or cirrhosis remain at a considerable risk of developing HCC. And this makes lifelong HCC surveillance a critical component of our strategy. So Roche Diagnostics, it's a global leader in laboratory diagnostics with major focus on bringing innovative diagnostics products which addresses the unmet medical need. We recently launched two innovative assays, that's the Alexis HCV Duo assay, which is a dual antigen antibody assay, and the GUARD algorithm for hepatitis C and HCC surveillance and diagnosis respectively. So this masterclass is about leveraging cutting-edge diagnostics and strategies to enhance early diagnosis, improve linkage to care, and ultimately save lives. The objective of today's masterclass is to brainstorm on how best we enhance screening and early diagnosis to identify the infected individuals, strengthen the link between diagnosis and treatment, ensuring access to curative therapies for all, and implement HCC surveillance for at-risk populations. Our esteemed speakers, along with our distinguished panelists, will elaborate on these critical topics. And thank you so much for being here. And we have kept enough time space to share your perspectives and discussions. Welcome again. So before going on to our first session, one request is that you must have seen that there is a chart on each of the tables. We kindly request you to, during the sessions, to fill in those charts with sticky notes on what you think are the current screening strategies currently followed and what are the challenges, what are the unmet needs, and how do you feel this new essay will be able to fulfill those gaps. This is something which will be very insightful for us to learn and put in our strategies. So without further ado, let me introduce our first speaker, Dr. Tawesak Tanwandee, who has come all the way for us from Thailand. Dr. Tanwandee is a professor of Gastroenterology, Department of Medicine, Shri Raj Hospital, Mahidol University, Thailand. He is currently steering member and the past president of the Asian Pacific Association for the Study of the Liver, APASL. He is currently committee member and past president of the Thai Association for the Study of Liver. He is president-elect of the Gastroenterological Association of Thailand. He received his MD with first-class honor and gold medal and received the Thai Board of Internal Medicine Gastroenterology. He has also spent 2 years as a research fellow at the Department of Molecular Virology, Baylor College of Medicine in Houston, Texas. So his research interest lies in the treatment of chronic hepatitis B and C, hepatocellular carcinoma, and the cost-effectiveness of treating these hepatitis B and C infections. We welcome you, sir, for your talk on accelerating HCV elimination with a focus on the dual antigen antibody test. Over to you, Dr. Tanwandee.
Thank you. Thank you so much for a very nice introduction, and good evening to all of you to come to join during the discussion this evening. It is Friday evening. It may be it's family time, but I think you still come to join with us for the advancements of diagnostic. For the first thing that I'm going to touch upon going to be how can we accelerate the HC elimination, focusing on the use of dual antigen antibody test. Here's my disclosure. So just to briefly touch upon the problem and the goal of WHO for the next few years until 2030, where we need to reduce new infection by 90% and to treat at least 80% of those eligible for the treatment in order to reduce the mortalities of liver-related complication by hepatitis B and C by 65%. But as now, this is the status in 2019. You can see that. Let's be check. You can see that in two WHO region, in South and African region, and in our region, where Thailand, Myanmar, Bangladesh, India, Pakistan, we share the same region in Southeast Asian region. You can see that only 5% in our region are now treated. So we are far behind the goal that we would like to treat at least 80% to achieve the goal. So this could be the urgent issue if we would like to catch up with 2030, the goal by WHO. And for hepatitis C, the key message is to get the patient treated, because only the testing, the key message is to get the patient tested, because the testing is the only way that the patient can know their status of HCV. Because usually these viruses, both Hep B and Hep C, they're still asymptomatic and they do not know. So once they get tested, they know that they are positive for hepatitis B, and then you can start the cascade of care. But usually in the past, we have classical cascade of care from anti-CV testing, and then we need to confirm whether the patient is still viremic by using RNA testing and then link to the treatment. So these multiple cascades usually link to the dropout. This is an example even in the US. So among 100%, just about 50% know their status. But among this 50%, just about 27% had HCV tested. And then only about 2/3 of these receive prescription or receive treatment. So you can see that during these multiple steps of cascade, so there are going to be a dropout in every step, almost 50% dropout in every step. Now, when we look at globally, we have improved injection safety. We improved blood safety by screening both viruses, but we still low perform on harm reductions of new infection, especially people using drug. We low underperform for testing and also for the treatment. So globally, just only about 7% of the patients in the world are now treated. So there's more work to be done before 2030. Now, just to show you the background of hepatitis C. So on your left is the acute infection, and on your right is chronic infection. In acute infection, after a few weeks of incubation period, the virus going to be present in the blood, even before the surge of ALT. So just 1 to 2 days after the presence of RNA, the antigen going to be detected in the blood as well. So usually antigen and RNA going to be present almost the same time. However, the presence of anti-CV going to be a few months after the acute infection. So this could be late detection. In chronic situation where the patient with acute infection cannot clear hepatitis C. So they're going to have anti-CV positive. They have both antigen and RNA positive and fluctuations of ALT over the time. Now, the interpretation for the test in acute and chronic infection in early stage where this could be pre-symptomatic, where the enzyme is still normal. So only RNA or antigen can be detected, and there is no symptom. In acute, early or acute infection, this situation, anti-CV at the early infection still negative, but RNA is now detectable, and also the antigen. So just to clarify that the RNA and the antigen, the RNA is the part of the nucleic acid, and the antigen is the part of the protein. It is a product of nucleic acid. So if they have nucleic acid, they have the viremic, then they can produce the protein. Then the antigen can be detected. So in late acute infection, sometimes you can detect anti-CV. And in result infection or past infection, only anti-CV going to be positive. But in chronic, you can detect both RNA and anti-CV. Now, for the evolutions of confirmation of Hep C in the past, those days we got to go with anti-CV positive and then recall the patient to test for RNA. But back in 2016, where the dual antigen antibody test was first introduced, the EASL guideline already introduced the use of antigen as part of alternative for confirming the presence of RNA that can be replaced for the patient where the RNA is not reachable or it is more cost effective. So for the principles of Hep C dual antigen antibody testing, this is the dual test that perform in same reaction tubes. So they have synthetic antibody to capture the proteins of the virus, so the antigen of the virus. So in order to do so, we need to lysis the virus and to export the protein, and then we capture the protein of the virus. On the other hand, we have antibody testing. This is the same as anti-CV testing that we perform every day. So in this same reaction tube, you can get both result, antigen and antibody. So the interpretation can be in part of antigen. So it takes 9 minutes to lysis the virus and then export antigen, and then we can go for reaction, both antigen capture and antibody capture. And the interpretation can be if the cutoff index greater than 1, so then the antigen could be reactive or positive. So if the antibody cutoff index greater than 1, it's the same as the interpretation for anti-CV. So it could be interpreted as anti-CV positive. And we have combined results. So combine both results all together, whether antigen positive, anti-CV positive, or in some cases, antigen positive, anti-CV negative. I'll come back later. Now, the process during the acute infection, during this window period. So in this period, if you do not detect RNA or antigen, you will miss the Hep C infection because antibody takes from 6 to 12 weeks until it can be detectable. So in this period, so if we can detect RNA, but in this particular cases, because majority of the patient with acute Hep C, they do not have symptoms, they do not have jaundice or even symptomatic in majority of the case. So we may miss some of these cases. So if we can have antibody detect, RNA detection or core antigen detection, we can detect and pick up this subject. And then this can avoid further transmission and right away. The presence of Hep C dual antigen and antibody testing is more sensitive as compared with using conventional anti-CV testing, and even more sensitive than other products with dual antigen antibody testing as well. So this got to be positive at least 3 weeks before the presence of anti-CV conventionally. Now, this is the sensitivities of the test. So in this part, this represents acute infection, and this represents late or chronic infection. In acute infection, just to remind you that these group of patients, they still do not have anti-CV positive. Only RNA or antigen could be positive. So you can see that the sensitivities of Hep C antigen got to be almost 93%, almost as sensitive as RNA testing. Because in this particular group of patients, there is no anti-CV to neutralize the test, so the sensitivity is very high. But now, when we are dealing with majority of our cases, especially when we deal every day, is going to be chronic Hep C infection. In this particular case, they're going to have both RNA, antigen, and antibody present in the blood. So with the interference, so the sensitivity of detecting core antigen is lower. So in this case, 64% positive. But things in positive way. So if you can get the result, usually within less than half an hour, and then 2/3 of these patients who are viremic can be confirmed by presence of the antigen, and this can go for the treatment without RNA confirmation, and that will save time, save money, and then the more important thing is the patient can receive the treatment with the same visit that they come to the hospital. They don't need to recall to come back to get the drug because it takes just half an hour to get the result. Now, the correlation between Hep C antigen and RNA is just moderate because the interference between the Hep C anti-CV and the antigen detection is sometimes quite complex. So it can be detected down to 21 IU per mil, or in majority of cases, usually the virus needs to be more than 5 log to be detected by Hep C core antigen. But in normal setting, most of our patients, more than 70% going to be viremic with virus greater than 5 log in general. So majority going to be detected by core antigen. And this can be very sensitive for diagnosis, but it's not useful for serial follow-up because after the treatment, it's going to be discrepancy between the virus and the core antigen. Now, let me share with you the performance of the Hep C dual antigen antibody testing. This includes more than 26,000 samples, mostly from European countries, but also in many regions of the world. in terms of overall sensitivity, you can see that the different three groups, the patient with RNA positive, antibody negative, this is represent acute hepatitis C. So where the anti-CV is still undetectable. RNA positive, anti-CV positive, this represent chronic hep C. And RNA negative, anti-CV positive, this represent past infections or after the cures of the of hepatitis C. So you can see that 99.6% of these samples positive for dual hep C antigen antibody testing. Only one missed because this guy is just the acute infection with low viral load. And anti-CV is still negative, so they can miss some cases in this situation, in acute infection. Now, what about overall sensitivity in majority of the case, especially in chronic infection? And this represents the sample from various state of chronic infection, various genotype. You can see that 100% positive. So in this case, with chronic cases, all of them positive for anti-CV at least. So for the duo, we interpret both. So it can at least, in majority, at least they can have positive for anti-CV. But in some cases, for acute infection, they will positive for only antigen but not anti-CV. So any of these two tests positive that we call positive. Now, in general, especially in blood donor and in clinical routine sample, you will see that overall the sensitivities of detecting hep C duo got to be 99.9%, so almost 100% positive. So this, in terms of detecting hep C or for further evaluation, got to be almost 100%. And the most important part for the dual antigen antibody testing is the positive predictive values of hep C antigen. This is antigen. You can see that once the patient positive for hep C antigen, all of them got to be positive for RNA. So once the antigen positive, you don't need to go for RNA testing because all of these got to be positive for RNA. So it is 100% positivity. So you can skip RNA testing and you can go for the treatment because nowadays we are usually prescribe DAA where we don't care about genotype, we don't care about the viral load. What we need to know is whether the patient is still viremic or not. So this just confirm that they are viremic and then they can be ready for the treatment. Now, just to summarize for the interpretations of the use of dual antigen antibody testing, this is according to the latest ESO guideline in 2020. So once the dual test negative, then these patients, they do not do anything else. So they are free from hepatitis C. So in case that the test reactive, you need to look at separate part of the test. So if antigen positive, this is viremic, no matter the results of antibody, because if core antigen positive and antibody positive, this is the situation in chronic hepatitis where the antigen positive. And in case of acute infection, core antigen positive, but antibody still negative. So in this particular case, so you can go for the treatment. Now, the more important part is if only antibody positive, non-reactive. In this case, as I told you earlier, that about 64% of chronic infection can be detected hep C core antigen. So the rest of about 1/3 is not detectable. So in these particular things where only antibody positive, but antigen negative, you need to go further for RNA diagnosis. So in order to separate between low viremic or past infection. So if RNA positive, then you need, so if RNA negative, you can discharge the patient. Now, let me share with you the results of clinical data. This is a study from Thailand. We look at the patient who were positive for rapid diagnostic test using the anti-CV RDT. So among 649, 473 RNA positive. And then when we look at the Hep C dual antigen antibody testing, 334 positive for core antigen. So the sensitivity of detecting viremic in this population is 70%. So then in the patient where RNA negative, none of them positive for core antigen. So again, just to emphasize and this underscore the positive predictive values of core antigen is very high, 100% positivity. And then for the people who are anti-CV negative, none of them reactive for whether core antigen or anti-CV. So this could be 100% specificity. Another study, this is also from Thailand, we look at monoinfection and HIV Hep C co-infection. And you can see that both monoinfection and Hep C co-infection, the sensitivity of Hep C dual antigen antibody testing even higher. This is 87.5% positive in both in monoinfection and HIV co-infection. And this can go for the treatment without the RNA confirmation. Another study, so I bring you to South Africa. This is a study from Professor Wendy Spearman group. So she looked at the use of Hep C dual assay in public health setting in Cape Town Hospital. So overall, in healthcare setting, the sensitivity of core antigen was 62.2%. So roughly about 2/3 of the patients got to be positive for core antigen. And then when you look at in terms of core positive and core negative, you see that the core positivity got to be higher viral load. And actually, if the patient got the virus greater than 5 log, the percentage of positive got to be 70%, and 100% if the virus reach up to 7 log. Another study, this is a study that done, this is prelim data from Lyon, France, from Professor Fabien Soulim group. So they look at the use of duo in general population setting. So this could be routine use in the hospital, over 22,000 cases. And then with the use of duo, they got 297 positive for duo. And among these, acute infection were 3. In this case, 2 of 3 positive for Hep C duo. And then for the patient who positive for anti-CV and core antigen and anti-CV but core antigen negative, altogether there were 73 cases positive for. So the positivity in this study was 55%. However, in this study, 44, about 1/3 of the patient had HCV RNA less than 4 log. However, when you look at the percentage of positivity, you will see that if the virus greater than 5.6 log, the percentage of core antigen positivity is going to be much higher. And when they look back, because they didn't know why in that study there was such a high number of low viral load. So when they look back at the past clinical case of the Hep C in their hospital for past 5 years, 71% of their patients had the virus greater than 5.6 log. So it may be because of the storage issue that reduced the virus in that study because they used the storage sample. So if we calculate back with the sensitivities of detecting RNA more than 5.6 log at the percentage of 70%, so they should detect at least 70% of the patient, because the patient that have viral load greater than 5.6 log got to be about 71%. So just to summarize for Hep C duo, so it is very high sensitivity, so 99 to almost 100%. Very high specificity from 100%, so at least 99.9%. So you won't miss any hepatitis C infection in any situation. And for Hep C antigen, so once it is positive, this is equal to RNA positive. So you don't need to confirm by using RNA testing anymore. So that will save time and also save the money. And this is the result where the duo can be interpreted. This is the example, 2 examples from my hospital. So they gotta have antibody positive, antigen negative. So in this case, you need to go further for RNA confirmation to separate between viremic or past infection. Or in this case, antibody positive and antigen positive. So this can go for the treatment in the same visit. So let me share with the viral load. So in this case, the viral load was low, and in this case, the viral load was very high. Now, the value of Hep C duo in various populations of interest, so you can simplify the treatment algorithm. So it is one test, and then up to 2/3 of viremic Hep C can be detected and then can link to the treatment. And this can increase access to confirmatory tests and link to the treatment in the same visit. And this can be useful for high-risk population, even in general population, including in the situation where living in hyperendemic area. It shortens window period. So in the patient, during the window period, using anti-HCVs for screening can miss these people. So this can be very useful, especially in preoperative and hemodialysis to periodic screening for acute infection or acute exposure. It can be appropriate for screening, especially in some situations where production of antibody can be low in immune compromise, or in some situations where reinfection is high, for example, for people using drug or MSM. Now, just to summarize, nowadays, antigen confirmation for Hep C is recommended both for the EASL guideline, for the 2020 EASL guideline, and the WHO guideline recently. So this can be interchangeable between the detecting the virus or the antigen. So at the end of the day, you can have choices of seeing the patient. For chronic Hep C infection, you can go with the classical track for screening with anti-HCV, and then if anti-HCV is positive, we call the patient for RNA testing. And then if RNA positive, it may take a week or so, and then we call the patient for picking up the drug. Or you can have, in some situation, in some country, they have reflex testing. It can be lab-based or clinic-based reflex testing. For the lab-based clinic reflex testing, they draw the blood for one tube and then test for anti-CV. If anti-CV positive, then they use leftover sera for RNA testing. In the clinic-based, they use RDT, anti-CV, and wait for 15-20 minutes. If the anti-CV positive, we call the patient for venous blood drawing for RNA confirmation. Or you can start with anti-CV duo. For the Hep C duo, this is a single test. So if the antigen positive, no matter the antibody positive or not, in this situation, you can go for the treatment. And this, in chronic situation, that will account for at least 2/3 of the patient. And then for the patient who antibody positive but antigen negative, then you need to ask for RNA confirmation, and that if RNA positive, then they can link to the treatment. So, ladies and gentlemen, just to summarize, for Hep C duo assay, this will allow determination of both antigen and antibody in a single sample, and this is beneficial one step for determining of hepatitis C status. And the result of these studies suggests that Hep C duo provide high sensitivity for detecting chronic infection, and moreover, it could be very high specificity, especially when the antigen positive, it is 100% positive predictive value. However, some sample where antigen negative and antibody positive, you need to confirm by RNA testing. And these two, with a single step testing, can increase the access to the treatment, and this can reduce the turnaround time of screening and diagnostic and expedite the treatment for the patient. And this can scale up the treatment in our countries. With that, thank you for your attention.
Thank you so much, Dr. Tanwandee, for enlightening us with the clinical value of HCV duo, and also for sharing your experience and the global evidences, which definitely suggested that HCV duo can potentially bring about a paradigm shift in the HCV diagnosis and the HCV care cascade. So we will now move on to our second session. For this, we have Dr. Anand Kulkarni. He is the Senior Consultant and Director, Critical Care Hepatology, Asian Institute of Gastroenterology. He is the member of the Indian National Association for Study of the Liver and the Liver Transplant Society of India. He is a member of the American Association for the Study of Liver Diseases, the European Association for the Study of the Liver, the Asian Pacific Association for the Study of the Liver, the International Liver Transplantation Society, and the International Liver Cancer Association. He is also the associate editor for Journal of Clinical and Experimental Hepatology, Journal of Clinical and Translational Hepatology, and Journal of Gastrointestinal Infections. His research interests include alcohol-associated hepatitis, acute and chronic liver failure, hepatocellular carcinoma, and liver transplantation. So we request Dr. Anand to kindly come on stage for his next talk, and post that we'll open up the Q&A for both the sessions.
No problem. Okay. Good evening, everyone. I am Dr. Anand. I'm a pure hepatologist, pure clinician. So I think it's a mix of crowd of clinicians and microbiologists. I'll be telling you from my perspective, basically what we look for hepatitis C in routine practice and what we are trying to do, achieve something for India at national level and also to achieve a goal of WHO. We started this prevalence study and we also are trying to give some drugs to these patients or individuals in rural area of Telangana where there is limited access. We started this in March this year. April we initiated in collaboration with the Indian Institute of Public Health through AIG. We have screened around 2,200 individuals. 50% of them have fatty liver. Alcohol use is around 65%. Interestingly, if you see here, almost hepatitis B is more common than hepatitis C. This is general screening in rural population. This is not high-risk population screening. This is just a general screening where we have found HCV in around 6, HPSAG 24, retrovirus HIV in around 14. So HIV first is HPSAG, then we have HIV, then we have HCV. This is in general population. But if we go to a high-risk population and you check them, probably you will have higher prevalence, probably 15 to 20%. In Punjab model, where they have done for PGI, they have found around 35% of individuals had hepatitis C positive. Every individual, we were part of that project to do some statistical analysis, and where we have found that many patients used to get lost to follow-up. They never used to come back for treatment. Once we do some anti-HCV testing, they never come back for viremic testing. They don't come to take medications. We just, many of them, at least 20 to 35% of patients are lost to follow-up once they are diagnosed with hepatitis C. But what this changes, if these are the individuals which have been found to be positive, mostly 4 of them are obese, 1 of them has diabetes, 3 of them drink alcohol, all of them have high-risk factors that they develop cirrhosis to some extent. Somehow, fortunately, their liver stiffness, that is fibroscan, what we do, was all normal in these individuals. If you consider in rural population as a whole, India around 10 million population as who have hepatitis C in general, 0.3 to 0.4%. This translates into 45,000 of patients who are not being treated for HCV itself. So we are missing a lot of patients. When we call them and ask them to come for viremic testing, they don't come back. They say, I have given test once, so you don't, please call me. If you want to give some medications, give it to me, otherwise I'm not coming back. That is where HCV duo may be more beneficial in such situations. Screening at general population, screening in prisoners, where the risk of HCV is very high. In India, the prevalence of HCV in prisoners is around 7 to 8%, more so in men than in women. It is also more common in men having sex with men, where the prevalence is around 15%. High-risk spots are in Punjab and Northeast area, which we train. Almost every alternate week, we get 2 to 3 viremic patients who are being treated for hepatitis C. Although the treatment has been simplified to a greater extent, we still struggle to identify these patients and treat them. So this is what actually HCV says, that 1.3 million people died for viral hepatitis in 2022, and viral hepatitis and tuberculosis were the second leading causes of death after COVID-19. It can affect anyone. High-risk populations, as I said before, are pretty high. The prevalence may range up to 15 to 20%. But why? What is this virus? This is a flaviviridae, has around 8 genotypes, incorporating 90 subserotypes. The only problem with this virus is only 20% or 25% can clear the virus spontaneously, not more than that. So that is the problem with us. Almost 80% go into chronicity. All of them develop chronic infection. 25 to 30% develop cirrhosis over a period of 15 years. HCC is pretty common once they develop cirrhosis. 4% annually develop HCC if they are cirrhotic. So this is the risk factors what we see in these patients. But if I have a HCV infection, what we usually get calls in routine practice is for healthcare individuals who are getting infected, who get a needle stick injury. Then we struggle there to identify patient with if they have got infection or not. This is the commonest call. I struggle with hepatitis C. Hepatitis B is little easier to manage because of the availability of hepatitis B immunoglobulin. Since there is no vaccine or anything for hepatitis C, we struggle treating these individuals or identifying them. We may have missed many of our colleagues who have been infected with doing procedures, because there is a window of almost 6 to 8 weeks where we do not find any viremia in these individuals. Hepatitis C, if you get infected, only 25% may clear. Who are those? Female individuals, usually who have IL-28 polymorphisms, a younger age, who do not smoke or consume alcohol, are the ones who can spontaneously clear virus. Otherwise, most of them tend to develop chronic infection. Usually what we see in clinical practice is they are incidentally diagnosed when they undergo some or the other procedures. They have gone for some dental extraction or they have gone for mastoral checkup. That is when they come to us with being diagnosed with hepatitis C. More often than not, they may come to us at the end stage when they are decompensated with cirrhosis, have ascites or jaundice, or having diagnosed as hepatitis HCC. That is when we often see them. Very rarely we see them as coming earlier and screening them. Incidentally, they may be diagnosed, but we are missing many of hepatitis C even now. This is Harvey Alter, who got the Nobel Prize for, they were the individuals who had identified this virus. We had the honor of having him at AIG 2 years back at our liver meeting. He gave a wonderful talk on how they identified this virus and what are their journey of identifying this hepatitis C virus. I think they are the ones who have been able to identify this virus and also cure to many of the patients, especially in Western world where they have free access to medications. Although there is a significant limitation to free medications in India till today. This is some of the studies. This is from Dr. Rakesh Agarwal, the JIPMER director, who has published recently saying that these generic available medicines are cost effective and they can cure the treatment hepatitis C to a greater extent than the ones which have been actually marketed, the traditional ones, which are pretty expensive to some extent. Indian versions of generic medications are quite effective. Although in the recent times, I'm not aware of the house experience. We are seeing some treatment failures. HCV, hepatitis C, we have been seeing some failures, at least 1 or 2, at least alternate months, we see that the hepatitis C treatment with Sofosbuvir has been failed and they have to be reinitiated on Sofosbuvir. Then we do some genotype testing. Very rare, although, but annually we see around 5 to 8 patients who have been failing these generic medications. This treatment is very easy, but the problem is with diagnosis of these patients, identifying them at the crucial point when they do not have infection, when they do not have chronicity evidence or have developed any HCC. So with availability of high DAS, HCV testing and screening is crucial to HCV elimination for us. That is what WHO says, that our aim is to eliminate hepatitis B and C by 2030, but very few countries have been able to be on target till today. The global WHO says that we have to reduce 80% of new infections and 65% of reduction in deaths due to hepatitis B and C. Only 4 countries, I think, Mongolia, there are some countries which I haven't heard of them, Cambodia, and some 4 countries, Dominica. There are only 4 countries which have been on the right path. Rest of them are still not been able to achieve this step of probably eliminating hepatitis B and C by 2030. So recently, WHO has come with many new guidelines on hepatitis B, especially to treat many individuals with hepatitis B if they have any comorbidities, or some of the international experts are suggesting that we have to treat every hepatitis B even if the HPSCG is positive. For HCV, we still need to do viremia testing to identify if the patient is at risk. So that is where we have to identify them early with a single prick of test, where probably HCV DO may be beneficial in such situations. In steps towards elimination, we need to have awareness. We need more population screening tools. Evidence-based policies are required. When we identified these individuals and called our local government for help to treat these patients, they were like, send them to us, we will treat them, you don't bother. I said, okay. So it's very difficult to cater these individuals and give them medications also. We should also focus on preventing the transmission of infections, and we should mostly have more tools to identify them early with scaling up of screening care and treatment. This is one published in, this is a meta-analysis where they have shown that this is by Professor A.C. Anand and Shalimar. The prevalence of anti-HCV in India, around 327 studies, it was on 0.85%. Asymptomatic blood donors, it was on 0.44%. In pregnant women, 0.88%. In blood donors, on 0.11 to 1.24%, and patients living with HIV is around 7.2 to 76%. Very huge burden, especially if the patient is retropositive. In HCV co-infection, it was around 1.89%. For elimination strategies, government is doing their steps. There are multiple steps which have been doing by government. That is National Viral Hepatitis Program. They are very active in identifying, but the individual has to go to the hospital and then tell them that please test me and treat me. Unless they go to the hospital, very difficult to identify these patients. Microelimination, some of my colleagues are doing in AIIMS Rishikesh, where they are going to smaller villages, high-risk populations, identifying these patients in prisoners and in those having in MSM population, where they are able to identify some patients and having treated them free of cost. We also should look for harm reductions, which the Punjab government is trying to do that. There is some efforts in northeastern countries also, but lesser to some extent. There is also the last point which I would like to highlight is free of charge treatment, which is most important for our population, which we still are lacking to a greater extent in our population. Apart from that, I think blood safety, we have significant improvement in blood safety. There is lower prevalence of hepatitis C in hemodialysis patients, which was a major struggle few years back. We don't have great struggle with those individuals in these days. And probably diagnosis, access to care is one thing where we have to work together. The global burden, there are 21% of patients who are living with chronic HCV infection, and 62% have been diagnosed. Only of them have been on treatment. So this contributes to around 290,000 of pair deaths. And in India, 5.5 million people living with HCV. There are around 1,40,000 new infections every year. And of them, 21% of diagnosed patients only receive treatment. 26,000 actually have died due to hepatitis C in 2022 itself. So there is a crucial step which we need to identify is identify them early with single prick test, allow early clinical intervention, minimize disease transmission because we don't have any vaccines as of now. We also need to stop the disease progression and reduce unnecessary healthcare costs, which can happen if the patient is diagnosed at a later stage. This is something about the same thing. 21% have been diagnosed with hepatitis C and only 62% are being treated. And around 20 to 30% deaths have been occurred due to hepatitis C, a repeat of the same slides. There is some barriers to the screening. There are major gaps in HCV testing and treatment across all populations. 8 out of 10 people with hepatitis C do not know their positive status, and it's time to find those missing millions. If you see the patient journey, usually it starts here that a patient is infected, then there is some screening test. Most of them do not get tested. A major challenge is diagnosis and then treatment, and then monitoring the follow-up. If I start a treatment for any of our patients, they usually do not come for follow-up for any of the reasons unless they develop liver cancer. That is when they come back to us. They come to us when they develop ascites or any other complications. Then we note that they haven't taken their medications properly. The viremia may still exist and the patient has developed liver cancer. Confirmatory test is the only way to do is now hepatitis C RNA, which probably can be gotten away by the presence of this HCV DO testing. So major challenge in any patient with hepatitis C is loss to follow-up, which we have struggled very frequently. For a routine till today, we have been doing this and we have been continuing to doing this, that we do testing of anti-HCV. We wait for at least 2 to 3 days for the HCV RNA to be available and then we start them on treatment. There are multiple barriers. If I ask a patient to get a similar, again one more HCV test, he said, you already done it, why you are doing this again hepatitis C testing? Although we have gotten away with genotype testing because of the availability of pan-genomic drugs, but we still require a single prick test which will be able to identify hepatitis C, antibody, and the viremia. This is what happens if an individual is infected. Within 1 to 2 weeks, the initial phase, there is HCV RNA and HCV core antigen which appears. After a gap of around 8 to 12 weeks, we have the antibody which develops. This is where we are missing a lot of patients. 5 to 12 weeks, where they are missing the hepatitis C individuals who may be infected, who may receive benefit by early identification and treatment. So 6 to 12 weeks is the diagnostic or serologic window period where we have HCV RNA and core antigen positive. Later on, we have anti-HCV positive. So as of now, for individuals whom we suspect, if we have a prick, we tend to do them anti-HCV at diagnosis, and then 3 months later again anti-HCV along with HCV RNA. If I am at that moment, probably I would be testing this every alternate week to identify a healthcare professional who may get infected later on. Because this is where he may be able to transmit infection to others that can be prevented by early identification of virus. So this slide, I think Dr. Tanwandee has already shown this. One concern where I found in this testing is where the HCV antigen is negative, but the antibody is positive. There may be small proportion of patients, but probably we may be missing around 1 to 2% of, probably will miss only 1 to 2% of those. But if the HCV antigen is positive, most of these individuals tend to have viremia. It may be in low levels or in high levels, provided if the antibody is high, probably they also have high viremia. If the antibody is negative, they may be having less viremia. The only concern is when the antigen is negative and antibody is positive, we may have to do a repeat testing of HCV RNA. If the DO is negative, then nothing to worry, the individual is not at all infected. And this test takes 30 minutes to be run, and also it can identify infection 30 days earlier than being identified on anti-HCV antibody. The same slide which Dr. Tanwandee showed, I would be happy to use this, this test basically to identify a patient after treatment. When I have an individual, when they come back with any other complications, instead of waiting for 3 days to know whether he has viremia or not, a single prick test would be very useful for me in clinical practice to know whether he is infected or not. The other thing where we try to evaluate these patients is, as I said before, there are some drug failures which are being noted in recent days. There I can use this test to identify if the patient has developed viremia again. As of now, EASL and only is the only one which recommends HCV DO testing for this patient, all the newly diagnosed patients. Otherwise, the other guidelines are still sticking to anti-HCV testing followed by HCV RNA plus minus DO testing. So EASL actually is strongly proposing for, EASL is European Association. The rest of the guidelines are still on the lacking on this proposal. WHO now has asked that we should try to identify them early, where we have been able to, if the individual is at high risk, then I would prefer really go for this DO testing rather than going for antibody, then going for anti-HCV RNA testing. So in routine practice, I may not be useful, but in high-risk population, if I'm sure that this is a high-risk population, I would probably go for DO testing upfront. It also recommends for retesting for presence of viremia after resolved infection. That's what I said, because if I have an individual who has been treated, if he comes back to me with complications, instead of going again to wait for its HCV RNA, I would probably go and get a DO testing done and then identify if he has developed any infection. Or then check for genotype if he has developed infection with other virus. Although the treatment may not change, but we usually tend to change the medicines based on the genotype currently. This is the multi-center study which showed that the accuracy and sensitivity and specificity of HCV DO testing is almost more than 98%. Both of them, it can easily identify hepatitis C antigen, as well as antigen is almost equivalent to a viremia in the multi-center study published from Germany, which has been published as abstracts in some of the journals and also one of the diagnostic journal, which again said that this ELSIS HCV DO testing is more sensitive and accurate to identify hepatitis C in early stages. It is probably, if it is negative, I would not be bothered to identify this patient whether he is infected or not. But if it is positive, yes, it will help me identify the patients of hepatitis C and start them on treatment. This is what our colleague has already shown this, that patients, if you see this in healthy controls, definitely there will be no HCV DO positive. All the antibodies are negative. If there is a high risk in population, if you see HCV DO, it offers a very good advantage in HCV and HIV co-infection, where the accuracy is almost 99%. and HCV monoinfection is almost 100%. So I would be very happy to use this test, especially if there is high-risk population. The negative predictive value is 99% and positive predictive value of 100%. It's a way to get to for any test, to be frank, according to me. I have not seen any good test than this. I would request Roche to give some of the kits for our patients in rural areas also. Who should actually be tested? Any unexplained chronic liver disease? Yes, we obviously do that. Hemodialysis patients, high prevalence populations where there is anti-HCV positive, HCV positive sexual partner, or birth cohorts at high risk, MSMs, multiple transfusions or thalassemia patients, injection or IV drug abusers. Most often we use this anti-HCV testing. Pregnant women, recipients of transplants, pre-operative cases. It also useful for post-transplant care where we have sometimes we tend to miss chronic reinfections if there is rejection. Especially with hepatitis C, if there is reinfection, then it may be positioned there as a point of care testing. Children of HCV mothers and retropositive healthcare workers, especially, I feel it's very important because they may be identified at early phase, and we may be able to prevent the spread of infection to his or her kith and kin. So in conclusion, identifying HCV in the population is essential to reduce the global burden of HCV and probably meeting the WHO guidelines of elimination targets. Screening coverage and linkage to care are widespread challenges to reaching HCV infected individuals. We need more public awareness and understanding of HCV. Recently, there is a BMJ paper which said that alcohol consumption has gone down and the IV drug abuse has significantly increased worldwide. This also includes India. Probably we may see again a surge of hepatitis C in later stages if we don't identify these individuals early. We need to have optimization of testing and care for antigen antibody assays and can provide opportunities to reduce the loss to follow-up individuals. This can be used as a diagnosis to achieve cure of infection and probably reduce the spread of infection. I'd be happy to take any questions if you have. Thank you.
Thank you, Dr. Anand. And I guess we can open the session for Q&A for both the speakers.
Hi, Anand. Nice talk. Do you have any experience using the DO in your practice?
I have been requesting them to give it to me.
Yeah, and so in your practice, how do you follow patients who have started on treatment with DO?
No, usually even with the RNA, we do not follow the patient during the treatment. I think at the best, as a guideline, maybe you can just to document at 12 weeks after complete the treatment to confirm SVR12. But eventually, I think many of them will, the drugs nowadays, the SVR rate is 95 to 99%. So I think once you get the patient treated, almost all of them could be cured. So even they do not come back for the confirmation, it's fine. You just give the drug. But in between, you don't need to follow because it's not like in the past where we used the interferon. It's more toxic and more side effect and more expensive. Then you need to have the guideline for early stopping rule. Then you need to follow the dynamic of the kinetic of the virus.
So unlike Japan, India, the only drug we have now is soft velpatasvir. We don't have the other newer drugs. So, and as Anand said, we are seeing some relapse with soft velpatasvir.
Relapse. Actually, when you look at the pivotal phase 3 studies of the software, recruiting more than 3,000 cases, 12 of them positive after 12 weeks of the treatment. 7 of them reinfection because of using drug, because of MSM fiber. Only 5 probably relapse. So relapse is very low.
And that's one question I wanted to ask you. So how do you, if you're using RNA, there's no way of knowing whether it's relapse or reinfection without knowing the genotype. How do you know it's a relapse or a reinfection when you're using RNA?
In the pivotal phase 3 study, they look at the genotype for relapse. The genotype is totally different. For reinfection, the genotype is different from the original. That was the part of follow-up during the registrations of software.
Most of the questions are in the next panel discussion has been covered by Charles now.
Okay. And one of the other clinical situation where it might be useful is screening for visa. That's where nowadays we don't, at least in South, in Kerala, we don't see many HCVs. And what we see is where patients are screened when they go for a visa interview for Middle East.
Okay. We actually screen, most of our patients, we drain a good amount of patients from Northeast, so we get a lot of IV drug abusers who come to us. And we see at least one new patient every week.
So nowadays, maybe because of the sensitivity of the test, we see a lot of false positive and HCVs during visa screening.
12% of false positive are very well known as antibody testing. I'm not aware of the false positive rates with this test, but antibody testing, it's 10 to 12% can be positive if they have any autoimmune diseases or if there are any medications.
And Middle East, they deny visas if they are HCV positive.
Okay.
So this could be one where.
But if but these visas, I think what I know is they require a letter that they have been cured and they are not able to transmit to others. That's where I think it can be positioned as safely using, I understand. But I think it's not been used in India in any of the, is anybody using this test as of now? Okay. Apollo hospitals. I think it's better to have her experience first. Start for the discussions. I know. And what's the approximate cost per patient?
Yeah, that's confidential, but yeah, it's much lower than the RNA, of course.
Okay.
But it's higher than the antibody alone. So 1.5 times, but I think given the volumes and all, I don't think so that's going to be limiting. And that's what I was telling them, somebody has to start it. Because once you start it, then you incur volumes and then we can ask them to bring down the cost. So, if cost becomes detrimental for us to start something, we never reach anywhere. So somebody has to start it. So Apollo will start it.
Okay.
And then we'll get them the cost reduced on volumes. And then I think it can go to rest of the country also.
But only thing is, how many of them will be identified on this test? How many have been able to identify? These are all.
We have not been able to get a case where there is core antigen negative, and because we validated it, we used our pre-tested samples and then we did the validation study. It was not used live on patients. So we didn't have a sample, we couldn't get that fourth category, which is where you have to still do a RNA testing. Others all was very good. Actually,
so you
we are quite
tested only
happy.
Those who had RNA positive, and then you got this confirmatory result that DO is also positive.
Yes,
okay.
yes.
As a screening.
And then
As a screening.
How many percentage of that RNA positive sample positive for core antigen in your validated?
I think it must be. It was done by microbiology department. So I'm not sure on the breakup of the numbers, but I think we have done total of 100 tests.
If we include this, I'm not aware of what is the House opinion on including this as a part for master health checkup. Many of our colleagues in IT hubs, they are undergoing master health checkups. So is there any benefit of, do you think it is beneficial for including this test in master health checkups as well?
Of course, we are sitting in this forum and we have to say yes.
You will say yes, I know.
That's what I was coming
say.
to. Yeah, but then I think we have to see the overall picture in the master health check. I don't know whether we can really go straight away on the screening, but yes, we can take a pilot project. I think it's interesting that we just do it on 100 and see how many positives, and then on basis the result, we can include it in the in the APHC packs, especially the higher end ones. Apollo offers something which is called, platinum and stuff. So there definitely these can come.
And that depends on the incidence of HCV in your population, right?
Yeah. that's
So,
what-
most health checkups, I don't think, yet to see a anti-HCV positive from a health checkup.
Okay.
And
we see here and there 3-4 positives.
one other situation is for when they're initiating dialysis. So, yeah, we get anti-HCV positive and then patient is sent to, most centers ideally it should not be done, but then they deny.
I think high-risk populations, I also agree that transplant populations, hemodialysis patients, prisoners, I think they are all, I mean, they can be screened with this test.
I think I agree with you in terms of using in hemodialysis, because in our hospital we skip anti-HCV alone. So all the hospital 2,500 bed facility we use only dual. And in the patient listing for kidney transplantation, we need to follow to screen every year to see whether they got new infection. So we found some cases where antigen positive, both antigen and antibody positive, because many of these got to be chronic infection after the cure, and then they got new infection during hemodialysis. So we pick up some reinfection during periodic screening with Hep C duo.
That I think in India, the prevalence of HCV, especially in dialysis, I think has decreased significantly. I know out the house opinion, but I think there is some reduction in the prevalence of hepatitis C, especially in dialysis patients recently. After around in the past 5 to 8 years, we have not been seeing so much of hepatitis C.
And also coming back to the question on whether should be included in the preventive health checkups, I think we really need to be very sensitive about it, given the sensitivity of this test per se on the source of infection the person gets. So if you see, most of the times HIV also is not included in the preventive health checkup packages.
Yeah.
Because that may just deter the public from confidentiality, consent, where did you get it? And if they have two labs offering the preventive health checkup, one has HIV, one doesn't have, mostly they'll go for the one which doesn't have.
We don't have.
Yes, we don't have. So again, same thing for HCV, it applies.
Can you please introduce yourself?
Yes, sorry. Check. I'm Dr. Sandeep, infectious disease specialist from the Ramaya institutions. Probably I would put this test along with when I'm suspecting HIV. I would probably co-test this because we've seen a lot of HIV and HCV co-infections. So rather than a preventive health checkup, but if I would like to test for HIV, probably I would put this test along with it, rather than just the antibody test where a lot of false negatives would come because of the immunosuppression by the HIV per se. So I would probably put.
And Rama has a big dialysis unit. Have you seeing
again,
a lot of...
I completely agree with you. We've been seeing a lot of trends decreasing with HCV in our hemodialysis units. Probably now I would go back to my med onco team and the rheumat team, where before we start on immunosuppression, we do the antibody test just for HCV and then start on rituximab or MMF. Probably this test would definitely come for my rheumat patients and med onco patients.
I think that's a good point actually for patients who have been planned for chemotherapy or rituximab therapy. HPCG and HP core totally is recommended. I think HCV DO can be positioned there as well.
Yeah.
I agree. That's what I thought, because there is nobody to take it. I said, let's finish off the panel discussion.
Thank you so much, Dr. Anand and also Dr. Tanwandee for the Q&A. We now move on to our next session, which is now focusing on the clinical utility of PIFCA and GAR in HCC surveillance. And for this, we have Dr. Charles Beneckel. He is the senior consultant in hepatology and liver transplantation from Astor Hospital. He is the secretary of the Liver Transplant Society of India, and he's the co-chair of the Liver Transplant Society of India Guidelines Task Force. His area of interest include acute and chronic liver failure, hepatocellular carcinoma, and liver transplantation. I request you, sir, to kindly come on stage.
Thank you, Roche, for the kind invite, and good evening to you all. And in next 15 to 20 minutes, I'll be talking on the utility of PIPCA and GAD in hepatocellular carcinoma surveillance. You want to go full screen? So we know that liver cancers are the sixth most common cause for cancer worldwide, and is the third most common cause of cancer-related deaths. And the 90% of liver cancers are hepatocellular carcinomas. And when you look at the prevalence, it's more common in the East. About 3/4 are from Asia, and the most common cause for hepatocellular carcinoma in Asia would be viral hepatitis B and C related. Over the last few decades, we are seeing increased incidence of alcohol and NASH-related hepatocellular carcinomas. And other rare causes of cancers would be the other causes of cirrhosis, like the primary biliary cirrhosis, hemochromatosis, glycogen storage disease, Wilson's, and various demographic and epidemiological factors are predisposing to cancers in our patients, like diabetes, obesity, smoking, alcohol. So all these risk factors leads to increased incidence of hepatocellular carcinoma in our community. And when it comes to India, it's more common in males. It's the age group would be around 40 to 70 years. And unlike the rest of Asia, we are seeing more and more of alcohol and MSLD related hepatocellular carcinomas. And this is, we all know the BCLC guidelines, the treatment algorithm, and the BCLC divides hepatocellular carcinoma into, BCLC divides hepatocellular carcinoma into 4 grades, that's from A to D, and there's a very early stage called stage 0. And if you fall into the first 4, that's a very early, and a subset of intermediate stage where transplant can be offered, we can have a curative treatment, and the 5-year survival is more than 60%. So we should aim to diagnose our patients in the very early or early intermediate stages, so that we can offer them a curative treatment like the resection, ablation, or transplant. And this is one of the first studies that looked at the surveillance for HCC in patients with chronic liver disease and hepatitis B. This is from China and published in 2004, where they screened chronic hepatitis HB-related cirrhosis. There were 18,800 patients, and they used AFP and ultrasound every 6 months to screen these patients. And what they found is that with the surveillance of using AFP and ultrasound, they could detect early stages in 60% of the patients. And the mortality could be brought down by 37% with this screening compared to the control group who did not have screening. So if you screen the patients, high-risk patients, your cirrhotics, your chronic hepatitis B patients, and if you can diagnose them early in the early stage, you can improve their survival for hepatocellular carcinoma. And this is a meta-analysis by Singha et al. That was published in 2022 that again showed that with screening, you have improved early detection, more of curative treatments can be offered, and there's a more overall survival. And screening, the benefits of screening outweigh the harms of screening in your patients with chronic liver disease or chronic hepatitis B. And this is the various guidelines across the globe that recommend screening for any patient who has got a high risk. That's more than 1% incidence of hepatocellular carcinoma, and all your cirrhotics fall into this category, irrespective of the etiology. And when it comes to chronic hepatitis B, any patient with the annual incidence of HCC incidence of more than 0.2% should be offered screening, and this include patients with age more than 40 in males or more than 50 in females, persons from Africa, persons with a family history of hepatocellular carcinoma, and HB score more than 10. That's a score that we use to stratify hepatitis B. And the gray areas are patients with hepatitis B who has been treated and who do not have cirrhosis, patients with hepatitis C who have got stage 3 fibrosis and non-cirrhotic NAFLD, because we are seeing more and more of non-cirrhotic HCCs in patients with NAFLD. That's a non-alcoholic fatty liver disease, but there's no guidelines as of now to screen them. But in spite of all these guidelines and all these recommendations, still we are making the diagnosis HCC is made very often, very late, and we are not able to offer a curative treatment for more than 70% of our population, of our HCC patients. And why is this? It's because of the sensitivity of the existing treatment modalities. As if you use the ultrasound alone for screening, the sensitivity ultrasound alone is only 45%. That means it will miss around 55% of your patients who have got HCC. And if you add a tumor marker like AFP to ultrasound, the sensitivity can be increased to 63%, but still it's not sufficient to dictate most of the patients with hepatocellular carcinoma. And there's an unmet need for a specific and sensitive surveillance modality. And the other reason why we are not picking up these patients with the hepatocellular carcinoma is the implementation of the surveillance recommendations. In a country like US, where there are around 6 lakh cirrhotic patients, and if you look at the annual incidence of 2% of hepatocellular carcinoma, there should be at least 18,000 patients with HCC every year, new patients. And you should, if you look at the screening, if you strictly follow the screening guidelines with ultrasound AFP, you should pick up 63% of these patients because of the sensitivity 63%. That's around 11,300 patients, new patients HCC should be diagnosed every year. But if you look at the real world experience, we are seeing that only 15 to 25% are diagnosed every year. That's around 2,000 to 4,000 patients, new case HCC are picked up every year in the US. So that means that we are not actually implementing, it's not the sensitivity alone, we are not actually implementing the guidelines of strict surveillance to our population, high-risk population. And this ESL and both ESL and the International Liver Cancer Society has come up with a white paper, which they say that to improve the surveillance, you risk stratify the patient into low risk, intermediate risk, and high risk. So that low risk patients are patients who have got the risk less than 0.2%, and you don't need to use surveillance in them. Intermediate risk patients are patients between 0.2 to 1%, and this group of patients, you might still use the ultrasound and AFP. Whereas there's a subgroup of patients who have got high risk for HCC, and they should have very aggressive screening with newer modalities like the newer biomarkers and abbreviated MRI. Now, if you look at Japan, I talked about US, but if you look at Japan, Japan is one country that has implemented the risk stratification for screening, and they divided the groups into high risk and extremely high risk groups. And extremely high risk groups undergo vigorous screening with ultrasound every 3 to 4 months, tumor markers every 3 to 4 months, and dynamic CT or MRI is done every 6 to 12 months as an option in the high risk group. And you can see that because of this high risk, because of this aggressive screening strategy, Japan and Taiwan, around 55 to 60% of patients are diagnosed in the early or very early stages, so that they can be offered a curative treatment, unlike the rest of the world where only 15 to 25% are diagnosed in the early or very early stage. So, as I said, how to improve the early detection of hepatocellular carcinoma? One, it could be by increasing the surveillance rates. We can promote, we can educate our colleagues, and we can educate the patient to come back for every 6 monthly ultrasound AFP, and we can do aggressive screening. And also we can improve the compliance on the patient aspect. At the same time, we can refine the screening strategies by including the newer modalities like newer predictive markers, machine learning or deep learning. Algorithms can be used to risk stratify patients into various very low or intermediate or high risk patients, so that we can risk stratify the screening. And we can use newer modalities like liquid biopsy. Liquid biopsy can be used for early detection of hepatocellular carcinoma. And patients, some of these patients, high risk patients, can be screened with abbreviated MRI. Abbreviated MRI is a limited sequence MRI that can be used to screen for hepatocellular carcinoma in the place of ultrasound. And that is the advantage, that it takes lesser time and it's lesser cost than your routine MRI. So either by improving the surveillance rates or by refining the screening strategies, we can improve the early detection of hepatocellular carcinoma in our practice. Now coming to PIVCA, it's a protein synthesized by liver under certain circumstances like hepatocellular carcinoma and vitamin K deficiency. And it has been used for screening screening and diagnosis of hepatocellular carcinoma. And this is a meta-analysis of 38 studies that looked at the PIVCA for the diagnosis of hepatocellular carcinoma and showed that PIVCA has got a high diagnostic efficacy and high specificity for diagnosing hepatocellular carcinoma. And in the study that looked at AFP, PIVCA, and combining AFP with PIVCA, it showed that with AFP alone, the sensitivity was only 52%, whereas for PIVCA, had a higher sensitivity of 87%. But when you combined PIVCA with AFP, the sensitivity rose to 92%. So combining PIVCA with AFP maximizes the sensitivity for detection of HCC. And hence, this could be a potential tool for screening patients with screening high-risk patients with hepatocellular carcinoma. And again, this another meta-analysis has showed that looked at AFP and PIVCA, and it showed that AFP and PIVCA combining AFP and PIVCA, it's got a higher sensitivity, specificity, and area under curve for diagnosing hepatocellular carcinoma compared to using AFP or PIVCA alone. And coming to GAD is it's an in vitro multivariate diagnostic test that provides a semi-quantitative result, and that includes the age, the gender, and the two biomarkers AFP and PIVCA, and it gives you a cutoff value of it gives you a semi-quantitative value, and the Roche has used a cutoff value of 2.57 for saying GAD positive or negative. And this study that developed the GAD and validated GAD, and you can see that in the development cohort, the area under curve for diagnosis of HCC was higher for GAD compared to AFP or PIVCA alone. And same was seen in the validation cohort also. The GAD had the highest area under curve of 0.90 for diagnosing hepatocellular carcinoma, both for early stage and the all cases, for all stage. So the first graph on development cohort is for early stage, and second is for the all stages, and same with the validation cohort. And it was seen that in the same study, it was shown that across all disease stages, across all etiologies, and across all geographical population, that's across both Caucasians and Asians, the GAD had a better sensitivity and specificity and area under curve for diagnosed hepatocellular carcinoma when compared to AFP and PIVCA alone. And in the same study, on the validation study, they looked at GAD versus GALAD. GALAD is where they use three markers. That's gender, age, AFP, AFPL3, and the PIVCA. So when they looked at GAD versus GALAD in the validation study, they found that the area under curve was similar for GAD and GALAD. So there was no advantage of adding an additional tumor marker to GAD in this population, and that added only to the expense and the expense of the test. And this another study that looked at GAD versus GALAD for diagnosis of hepatocellular carcinoma and chronic hepatitis, and again it's a similar finding. It was shown that the area under curve and the sensitivity and specificity were similar for GAD and GALAD, and adding FL3 had a negligible role in the diagnosis of hepatocellular carcinoma. And when you combine GAD with ultrasound, the sensitivity for diagnosing early cancers was 70%. So mind you, for if you use AFP with ultrasound, for all cancers, the sensitivity was only 63%, whereas the study showed that for combining GAD with ultrasound, at a 70% sensitivity for detecting very early and early cancers, hepatocellular carcinoma, so that you can offer a curative treatment for many of your hepatocellular carcinoma patients. And again, this is a multicenter study from Europe that looked at GAD versus GALAD, and similar findings where they showed that GAD and GALAD has a similar efficacy, the sensitivity and specificity and area under curve for diagnosis of early hepatocellular carcinoma. And the studies, multiple studies that look from East and the West that looked at the cost effectiveness of adding GAD to the screening algorithm. So one of the concerns of adding GAD is for any screening or surveillance test to be effective, it should be cost effective also. So this is a study that looked at the cost effectiveness and shown that adding GAD to ultrasound, because it detects more cancer early, can offer curative treatments, and there's less of hospital healthcare utilization. It's cost effective to use GAD in your screening algorithms. And this is our experience with GAD. We have been using GAD from 2024 Jan. This 1.5 years. We have 324 patients, of which 146 are HCCs and 178 at CLD, chronic liver disease without HCCs. And this across the spectrum, that's from BCLC A to D, the GAD had a better area under curve for diagnosing hepatocellular carcinoma compared to AFP or PIPK alone. So coming to the clinical utility of GAD in HCC surveillance, you can see that GAD has got a higher sensitivity and specificity for diagnosing early stage hepatocellular carcinoma. And when combined with the ultrasound, the sensitivity increases to as high as 90% for diagnosing hepatocellular carcinomas across all stages. And it demonstrates good cost effectiveness compared to ultrasound plus AFP for hepatocellular carcinoma, and can lead to a better outcome for HCC patients. So the take-home messages would be that we need to have better screening strategies for our hepatocellular carcinomas, because the current screening strategy of AFP and ultrasound has a sensitivity only of 63%, and GAD with ultrasound, it improves the sensitivity to around 90%. So in future guidelines, the GAD might come in the guidelines for screening of hepatocellular carcinomas along with ultrasound for your patients at high risk for hepatocellular carcinoma. Thank you. Happy to take any questions if you have any. It's Onam in Kerala today. So.
Thank you so much, Dr. Charles. We now have Dr. Tanwandee. Would you like to share some of the case studies on his experience using the GAD and the GALET?
While we are arranged for the podium for the panel discussion, I just want to share with you a few cases of using GAD score for screening in addition to the ultrasound, just to show some cases that we can pick up by looking at the abnormal GAD score where the ultrasound was normal or some almost normal, and that can be easily missed by the ultrasound alone. Can you have the mic? No, can you switch to the computer? Can you switch the because there's no. This is the 55 years old male chronic Hep C after SVR and alcoholic cirrhosis. So during the periodic follow-up with the ultrasound and the GAD, in addition to the ultrasound, so you see that. So in this case, the abnormalities of the ultrasound was very, very minimal, where the PIPK2 went up. That just to flag us to our further confirmation. And in this case, if we calculate the GAD score going to be, the positivity going to be more than 2.57. So this is going to be abnormal. So normal or abnormal. So the cutoff for the CAS score, maybe we need to determine for individual population, but in general, whether in the Western, that for the the study that we include both Caucasian and Asian, so the cutoff remain quite similar. So the CAS score was elevated, and then we sent him for CT scan, and we did find the small lesion just a bit bigger than 1 centimeter, and then he underwent ablation. Another patient, and this is very interesting. You can see that the elevations of PIPCA2 was very, very high. In this case, the ultrasound was normal. There was no lesion detected by the ultrasound, but we pick up the case by abnormal PIPCA2, and the CAS score going to be very high as well. And then we send him for MRI. You can see big lesion in the caudate lobe that was missed by the ultrasound. So by addition of the CAS score in the routine ultrasound, that can pick up, especially in high-risk population, in the patient with cirrhosis, in the patient where they might be obese, or in the patient with advanced cirrhosis where the ultrasound can get heterogeneous. That can be more difficult to pick up. So these are few cases that I just would like to share with you.
Thank you, Dr. Tanwandee. I guess during the panel discussion also, those questions can be addressed. So we will, because we have panel questions on PIFCA-GAR also. Yes. So we will be moving towards the panel discussion session, which is on leveraging biomarkers for advancing liver disease management. And this session will be moderated by Dr. Anand Kulkarni. And the speakers for this session would be Dr. Tawesak Tanwandee, Dr. Mamta Soni, who is the Laboratory Director for Apollo Main Hospital and Senior Consultant and Head of the Department of Hematology and Clinical Pathology, Dr. Charles Benekel, who is the Senior Consultant Hepatology and Liver Transplantation from Esther Hospitals, and Dr. Angelina Mendoz, who is the Consultant Microbiologist and Infection Control Officer from Ramaya Memorial Hospital, Bangalore. We request the panelists as well as the moderator to kindly come over stage and take over the session. And one request to all the audience, there is the chart which is there on your table. During the session, we would request you to kindly fill in your thoughts, even with a pen also, if not with the sticky notes. You can just put in your thoughts on what are the current strategies and what do you feel are the gaps and how do you feel these gaps can be fulfilled.
Shall we start? Okay. The first question is for Dr. Angelina. Hello? I think I need to be loud. No. Can you elaborate on the benefits of HCO-DO and testing for active cases and the populations where it can be beneficial?
Yeah, thank you for the question. So the benefits of the HCV duo in the population, you said. Can you just repeat the question?
Yeah, in special populations, where do you think that, where do you place this HCV duo testing in clinical practice?
Yeah, special population, as we heard in the talks earlier, the hemodialysis patients and patients who receive multiple blood transfusions also, those kind of patients, and immunosuppressed, like those who will be put on the immunosuppressants, like those with autoimmune diseases, and those kind of patients, definitely this test will be helpful.
Do you suggest starting treatment on if the antibody and antigen are both positive? I have been doing that. Anybody, do you start treatment on such patient? Do you suggest starting treatment in such situations where the DO testing is positive?
Yes, actually in Thailand, the government, the test for confirmation, anti-CV and anti-CV antigen and RNA, all of these tests are free of charge, and as well as the drug for all Thai population. So it can be either antigen or RNA that can confirm viremic. So once, especially in my hospital, because all of anti-CV tests could be dual. So then one antigen positive, then we can give the drug.
Okay. Everybody undergoes DO testing.
In my hospital, yes.
Dr.
A
Mamta?
lot of fund is being given, and that's why Thailand is going zero on HCV, or I mean, there's a drastic reduction on HCV incidences.
Oh, it's not that fast. I think we try to catch up with 2030, where we need to increase the screenings. I think we might meet that, but still, even everything is free. Uptake for two-step testing, uptake for RNA confirmation or antigen confirmation got to be just about 50%. So the anti-CV positive, just about 50% will come back for RNA testing. So if we can move to dual test, and then the patient can get the drug within the same visit, that might increase the uptake of the drug.
I think I'll just extend her answer also, because see, the biggest advantage with the duo is that the patient doesn't have to come back again in many of, I think I would say in 75 to 80% of the cases. And also somehow, there's always a question which comes that why don't you do a reflex testing? If the antibody is positive, just go for RNA. But it's easier said than done, because the cost of the two tests are miles apart. Going for an RNA confirmation is very, very expensive. And when we are going for a reflex testing, actually the cost has to be borne equally by the negatives also, and then only you can have the reflex testing done. And that just doesn't work. So actually, I don't think so that reflex testing can happen in commercial scenarios, in private hospitals and stuff. If the government loads the government organizations with money, they can go for it. So I think that is also where the significance of this duo testing is immense.
How is your confidence regarding this testing of HCV DO? And how do you think it impacts our care cascade in clinical practice?
Definitely. I think I got the heads up from the Department of Microbiology. I'm not a microbiologist, I'm a pathologist, and I'm here in the capacity of a strategy decision maker, because I'm also the Chief of Lab Services for Central Reference Lab Apollo. So before coming here and as they were kind of commercializing the kit and looking into commercials, I do take a feedback from the department and how is it, and the feedback was pretty positive. So she just told me, our microbiologist told me, ma'am, if you can circumvent the cost and sanction the cost, I think the kit is very promising. But then if you see the tangible and the intangible benefits of that cost, especially for a patient who is coming to specialized care setups, these cost factors, somehow they get kind of a bit navigated with the outcomes, because we are always looking into clinical outcomes more than the cost.
And actually, this is direct. You are talking about direct cost, but if you have to recall the patient to come back for RNA testing and then waiting for the result and come back for picking up the drug, and then indirect medical cost for traveling, cost for absence from work, that can be even more.
And the many patients the hospital loses. So there also the hospital is losing revenue.
Charles, what is your opinion on HCV testing?
Again, that depends on the prevalence or incidence of HCV. Now, it has been very, very low in our population. We hardly see one case a month nowadays.
I think, as you said rightly, in Kerala, it should be used for travel purpose, like approval of visas.
Yeah, or we could use, as I said, in screening patients who are about to undergo immunosuppressions, screening patients with on dialysis for dialysis. So such high risk population, yeah, we should.
And on that point, what Dr. Sandeep, right? Yeah, I had made for post-transplant patients, I felt it might be useful because we see a lot of rejections post-transplant in hepatitis C. Then we are confused whether it is viremia which is causing this rejection. What is it?
Yeah, that's true because if we have to wait for the RNA, it's going to take a week. So this is a test where we know whether it's HCV or not.
Okay, yeah.
That's one situation. Yes.
How do you handle low viremia cases, Professor Tanwandee? How do you handle low viremia cases? You know that the patient has infection, but the virus levels are pretty low. And what is the value of this test in such situations?
No, in case that if if you are using RNA testing, it's not the issue, right? But for the low value,
But if it is 2 to 3 times higher, it's little difficult to use as a screening test in general for us especially. Dr. Mamta, your experience on this test, I think you shared some of the insights on your experience. How confident are you that yes, it will detect all of the viremias?
Definitely. I think it is very, very promising. Only thing is that we are still validating it. We have not done as many numbers to kind of say things very, very, statistically significantly. But whatever we have done till now on the 100 test, I think it is very promising. And we haven't had any of those false positives and false negatives. And given the TAT, like in single day, in single batch, you can give the results. I think it is very promising. Definitely.
Angela, in your experience?
Very soon, I think we'll be using it in routine.
In routine practice in all the Apollo hospitals?
Yes.
Yeah, with regards to our experience, we will be getting a kit. So we'll start a validation, but from whatever we have studied and heard about the kit, I think it will add to our diagnostic stewardship because as diagnostic stewardship, we need a test which can we can hold the patient and it's a single test. TAT is well within our routine TAT and cost-wise also it won't be as high as. So patients will be linked to care more efficiently. So it will add as a laboratory physician. I always want a test which adds to my diagnostic stewardship. So the right test for the right. So it will add to that. So I'm definitely hoping to use the test and see how our management will incorporate it.
I think Bangalore definitely needs it because in Bangalore I took 45 minutes to reach from Hyderabad to Bangalore and I took 1.5 hours to reach ITC. So I would be very happy. I should be using if I'm in Bangalore, I would definitely use this test. If a patient goes back to home, he won't be coming back. I don't think he'll come back to get a test again.
And I think another important thing is that it doesn't require too much of an infrastructure investment.
Yeah.
On routine equipment, that is also very good because most of the times the deterrent is when you have to put in some infra, you have to get an equipment and the water and the stuff like that. Here is that you just have that kit and rest of the cost is covered. So that is helpful.
Your experience, Dr. Charles, I think you shared your experience on PIVCA and GAD. Coming to the next one, HCC part. So we have been using GAD and PIVCA and GALAD. All these are tested by different, Roche is one of the providers for GAD. GALAD is by something else. And there are multiple other such things. Which you think is the best till date you have been using?
No, our experience is limited to GAD alone. We have not used GAD as of now. And as I showed, we see the sensitivity of GAD is higher than that of AFP. sensitivity GAD with ultrasound is higher than that is the AFP with ultrasound. But that's one question I wanted to ask, Prof. Because we are seeing a lot of false positives with PUBCA. And I'm sure we had that discussion in the liver group where people are asking that they're seeing a lot of false positives with PUBCA. You have high PUBCAs, but CT is normal, MRI normal. So do you see that in your practice? And even in the study that I did not put the specificity is very low in that.
Okay, I think the most important thing for the beef card, this is a part of apoprotein that is not acetylated. So in case that the patient using anticoagulant, warfarin, whatever, you can cut the PIPCA level maybe 10,000 times more than normal. But in some situation where the patient with advanced disease, the patient with malnutrition, you can have high PIPCA as well. But that will be, I think you see the patient to see that in decompensated cirrhosis or in advanced liver disease, they can have high PIPCA without any HCC, because this is part that it's going to be because of carboxylations of the apoprotein is impaired. But yes, I did find some patients, especially after the treatment, when the patient got advanced liver cancer after test or after test treatment, and then the MRI did not find any lesion, but the PIPCA keep rising, sometimes in the range of 1,000. But we try to look for extrahepatic, and everywhere we did not find any lesion. But what I do is just to keep them follow up more frequently, every few months for the PIPCA, and then repeat MR with liver-specific contrast. I think at the end of the day, some cases we found the lesion, and most of them were infiltrative lesion that did not easily detected by the MRI.
Charles, have you seen any patient who has normal AFP, elevated PUCA, or normal AFP, mildly elevated PUCA, GAD score of 2.9, and you found a HCC?
Yeah,
He showed some interesting cases.
Yeah,
where
he just showed that case. Yeah, no, that's why there's a sensitivity difference of around 30% between the two tests. So you're likely to. There are a lot of AFP non-secretors, a lot of HCCs that are AFP non-secretors, and you see the PUCA elevated in them, and the GAD score would be positive. So we do see that, and nowadays for patients on waiting list and pre-transplant, we have switched entirely to GAD for screening.
Okay.
You're not using AFP.
One important thing what he mentioned was patients on warfarin. Recently, we got a new resident who was more enthusiastic in testing for HCC in a decompensated HCV patient again, and he got a PUCA done. PUCA was 26,000. I was on leave, so he got a PET CT done, saying that this patient probably has hepatitis C related HCC for sure. I went to the patient. I asked, "Do you have any cardiac problems?" He said, "Yes." Say, "And what are the medications you're on?" I'm on digoxin and I'm on warfarin. I said, "Okay." So,
I think this is very interesting, and I think if I would go for these biomarkers, I would go for the algorithm, not only single marker. For the Japanese, they look at single individual markers.
And that patient had normal GAD score.
Yes, but in the case where the AFP is marginally elevated, PIPCA2 marginally elevated, but it comes to the calculation with the algorithm. It got separation between normal and abnormal.
Yeah. One useful way where I found GAD was recently we had a cholangiocarcinoma because of hepatitis B. The radiologist was confused whether it is cholangio or HCC. We got a GAD score. GAD was 0.8 or 9.9. So we are pretty sure that it is not HCC. We got a biopsy done which was cholangio. So in situations, hepatitis B is also known to cause cholangio. So in such situations, probably GAD has more value rather than going for imaging, getting confused. We probably are sure that it is not HCC, probably more cholangio, which has dismal prognosis than HCC. So I would place GAD in where post-transplant monitoring, pre-transplant. Hepatitis B, we have not been able to find more of patients because on surveillance, most of them turned out to be normal.
No.
So hepatitis B, I think page B score still holds valid for us. Do you calculate a page B for all these patients of hepatitis B, or you just get them tested for PIVCA and GAD?
I think it depends on the incidence or the risk of the patient, especially in cirrhotic. That's going to be the highest risk. Actually, I just want to share you my study with GALA score, not the GAL score, that in addition to the L3. So prospective study comparing ultrasound 1,500 cases versus ultrasound plus GALA score and follow up every 6 months for a year. The criteria for exclusions of HCC going to be negative ultrasound 6 months after 1 year, that means 18 months. So the incidence of HCC for the arm of ultrasound was 1%. For the arms of ultrasound plus GALA score was 2.6%. That just recently presented at late breaker at the EASL this year. So we randomized the patient. There is no reason why the ultrasound plus GALA score got higher incidence of HCC. That is the reason why we got early cases that cannot be detected by the ultrasound. That has been shown by the two studies from the US that the biomarker can be detected at least a year earlier than the ultrasound. And actually, when we look at it in detail for the abnormal GALA score, majority of them did abnormal because of the PIVCA2, it's not the L3 part.
I think very valid point that GAT can help in identifying early HCCs. Hope the panel agrees with the early diagnosis of early HCCs. Although our patients tend to present at a later stage where all the markers are significantly elevated. Yes. But if the patient is on surveillance, I think they can identify early HCCs with GAD and GALAD.
And then they come back to that study. 80% going to be in the state of 0 or 1.
Oh, great. 0-1 is a complete curative intent therapy for these patients.
Do you use it for monitoring for the relapse, HCC, treated HCC?
Yes, we do. We have been using that. We just had a patient today who's...
after the treatment, right?
Yeah.
Yes. Yeah. I think sometimes, it's the same for the AFP. Sometimes after the treatment, the CT scan just, or MRI, no viable tumor, but AFP keep rising, or more frequently, PIVCA2 keep rising. You need to look for something. It may be at the margin or something. You need to closely monitor the patient.
I think radiological evidences are a lot more dependent on subjectivity also, who is doing it. So that way, these biochemical markers are more objective. All you need to do is that it has to go to a good lab.
Excellent point on that, actually. Charles, one question. What is PIVCA? There is some study that patients who receive vitamin K for HCC can have improvement in HCC. I mean, there is
in the PIVCA.
Yeah.
Yeah. So that's what some of these patients who had a false positive PIVCA, what we did was we gave a vitamin K and then repeated it. And we saw that it's coming down to normal.
So that doesn't occur in HCCs?
No. See, as I said, it might be related to our alcohol malnutrition. It may be a decount cirrhosis with malnutrition who have got a vitamin K deficiency. That might be the cause for the false positive results. So all these patients who had very high PIVCA, we do not see any lesions on CT. At least few of them have responded to vitamin K.
Do you plan to follow them up, as you said?
No, we have to follow them up because it might be that we are dictating we might detect a tumor later.
Dr. Angelina, what is your we'll come back to DO again. Can you help us understand the interpretation of DO testing, the antigen and antibody once again for the panel and
Yeah,
the
I mean,
audience?
it's very simple for those users who use HIV Duo. It's very simple because there's an antigen component and an antibody component. So the antigen result also, the kit also shows the antigen result and the antibody result, and the cutoff to index value, that the COI is 1. So if it is less than 1, it is negative. If it is equal to or greater than 1, it is positive. So the equipment, the kit, it will give out the results that way. So if the antigen is if it's a scenario where the antigen cutoff is COI is greater than 1, that means the antigen is positive. I mean, all those things are there in the literature, kit literature, and it will be, it's very easily interpretable that way. So it's just that 1 is that number, below that is whatever is detected below that is non-reactive, and above that is reactive. And then the permutations and combinations that we saw. If the antigen positive, antibody negative, there's an acute this thing, definitely it's an acute viremia, acute HCV. If antigen and antibody both are positive, it is somewhere just in that phase about 3 weeks, or 12 weeks, 8 to whatever after that. And if the antigen is negative antibody, then it may be just a resolved infection or later in the course of the infection. So that is a way how it will help us to identify, and we can give the results separately, antigen, antibody. In the same test, the beauty is the same blood sample, same assay. So,
Any questions from the hall? Anything to me?
This is difficult to answer. The higher the virus, the higher the percentage that can be detected by core antigen. But if you got the virus greater than 5 log, you got to have the chance of core antigen positive up to 70%. So in the lowest part, in some cases, even less than 100 IU per mil, it can be positive for core antigen, especially after the treatment. If you follow the core antigen after the treatment, sometimes you have less than 100 of the viral load, but core antigen still positive. It may be because of the protein part lasts longer than the virus.
Possibly the lack of a policy on screening many more is putting us into this situation where we do not have antigens which are negative, antibodies positive, and then correlation with the viral load. So even in our pool of cases, we never had any of this. We are still waiting that we can get something and get some more information.
For us, from treatment perspective, we don't treat if the RNA is less than 500. We usually don't treat. So if the this DO test misses 500 to 1000 or 500 to 2000, then we are stuck. I'm not sure whether to treat or not. Then again to retest them. So that probably the lower limit. I'm not sure. I'm not aware of the results. If anybody has any insights, they can.
The lower limit.
The lower. The question was, if the RNA is 750, can the DO test detect?
I told you that as low as 21 IU per mil, it can be positive. You see, it's very varied because it's going to be complex interplay between. So you put the synthetic antigen and synthetic antibody in order to capture both antigen and antibody in the blood, and then you got antigen in the blood and also antibody in the blood of the patient sera. It's going to be the complex interplay between the patient antibody and the synthetic antibody and the patient antigen and synthetic antigen. So it's not directly correlated with the virus. It depends on the amount of the antibody or the amount of as well as the amount of antigen in the blood.
But you say that the lowest limit it can detect is 21?
27, but that according to, but it may be one case.
Very difficult.
But we don't, usually we do not face that low viral load because in majority of cases, we are talking about detecting the patient, especially in untreated patients where usually the viral load is going to be 5, 6 logs or even more. So we don't care about that. In the lower part, that is very uncommon though.
We can have a study, somebody can sponsor. Of course, Roche has to sponsor, where all these core antigen negative, antibody positive, what is the correlation with the RNA numbers? If it is like really not significant, then all those core negative, antibody positive can be taken as negatives. Correct? If it is not
correct.
really falling into a treatable criteria.
Right.
This, I think,
We will have a
Along with Roche.
or a multi-center study.
Multi-center, correct.
0.03% was the one which was reported in that study on which was published in Diagnostics journal. But I think it will be very useful as for clinicians per se, for all of us. I think Roche will definitely support us. Dr. Mamta, what is your one pick? I mean, if you had to pick one key area for deploying HCVDO, where do you want to place it? Community screening, antenatal clinics, high-risk settings, and where do you prioritize and why?
I think it just depends upon where you are working. I would say that if I would have been working in a hospital which specializes in nephro, I would put these hemodialysis patients on this because I'll get substantial volume. I'll get substantial good answers to all these questions. And of course, if I'm working into an HIV kind of a setup, these patients will go there. But I think most of the risk categories which we have discussed so far, multiple transfusion, chemotherapies, if we are into onco, all these chemotherapy patients, drug addicts, injectable drugs, I think all of them are equally significant. It will just depend upon the center where we are working that we choose the cohort population. So if it is to me, I think we have a lot of patients who are dialyzing, so maybe I'll put them.
Charles, your closing remark on PIVCA and GAD?
No, probably in next guidelines, GAD and PIVCA will come up for screening for its hepatocellular carcinoma. And looking forward to that. And we know abbreviated MRI and the liquid biopsies, again, they are also coming up in a big way. So,
anything to add, sir?
I think one thing that I just to echo Professor Manta just mentioned that you need not to invest new things, new equipment. For the dual, you can use the same machine, the electric machine over there. For PIVCA as well, you don't need to buy proprietary machine for GARA score. And this is the machine that already been in your hospitals using for AFP testing, and then you just ask one order for the PIVCA tool, and then you get the GARA score calculated, and then you get the result within the same sample.
The CPRT is really helped if you don't have to spend on equipment and extra personnel, another trained manpower. So,
more affordable screening situations, Apollo can go ahead with testing all individuals with HCVDO. Otherwise, HCVDO probably has more place in high-risk populations or patients planned for chemotherapy, immunotherapies. GAD, I think, definitely very well valid marker to identify early HCCs. I think we will close the session. I don't think, are there any questions? Thank you, everyone. I think Roche can take over.
Very interesting that your site in the lab.
Thank you, panelists. Thank you for the excellent discussion. I'm sure I speak on behalf of everyone in the room that it was very insightful and everyone goes back with a lot of insights. My name is Karan Kampani. I'm with Roche Diagnostics Asia Pacific, our regional headquarters in Singapore. A big thank you from us in Singapore for making us feel so welcome. It's very warm and it's great to see so many people. I know there's a public holiday today. There's multiple festivals going on. And in spite of that, all of you are here listening, asking questions, which is great. I love the passion and I really feel warmly welcome. So a big round of applause for all of you first for being here. Secondly, please put your hands together for our esteemed guests. Dr. Tanwandee, thank you for sharing and joining us. Dr. Anand, thank you, in spite of the traffic and braving. Dr. Mamta, the same for you. Dr. Charles, I know you also just flew in, and it's also Onam, so happy Onam to you. But thank you for being here. And last, Dr. Angelina, thanks a lot for. Big round of applause. As I quickly think of the session itself, I was thinking of 3 E's came to my head as you were going through all the presentations. The first was on the importance of early detection, right? We talked about HCV duo and the ability to find these missing millions, right? There's 5 million people who are still infected, and more get infected. But with HCV duo, we have one additional tool, right? We already have a lot of tools, but one additional tool to really find people early with one test, to kind of simplify the cascade and not do these 2 tests, right? So we're very happy we have this. We have PIFCA 2. Thank you for sharing that, Dr. Anand, right? And you guys are pioneering this year. We see a lot of PIFCA use in Japan, in many other markets, but in India, we hope there's more and more recognition of this, and especially with the cases shared as well, right? Where AFP and PIFCA together add even beyond where maybe ultrasound can miss something. So catching patients for HCC early. Same for GAD, right? GAD is one critical tool or an algorithm which puts together many factors. And if you think of the 3 then, with HCV duo, with PIFCA, with GAD, we now have new tools that can help us in early detection, both for hepatitis, but also HCC in this liver management space. So I really walk away with that one key point on the importance of early detection. The sooner you catch them, the sooner you can treat them, right? And that's important from a patient point of view, from a healthcare system and cost point of view, which was brought up by you, right, Dr. Mamta? The second was really on evidence and expertise. I mean, I was sitting there and listening, and all of you were passionately sharing, what's happening in your labs, in your hospitals, in your clinics, when you meet patients, the cases showed here, the studies and the evidence. And all I would say is please follow the science, right? For us, it's very important. If something is helping us make a difference, cost apart. We take your notes on the cost, of course, but if it helps you in your care cascade, if it's helping patients, please put it into practice. So when you go from here, awareness is the first part, but really take the evidence. If you need more information, the whole team is there at the back. Ask them the tough questions, ask them for the evidence, but really follow the science and please put it into practice. I hope when I come back here, maybe in 6 months, or come and visit one of your hospitals, it would be great to see it in action and follow up on that. And the last is really the energy. I mean, the third E for me was energy, because I could feel everyone waiting to, put their hand up and share a question. I know the panel discussion was not even started, but we had already done a little bit of a Q&A before that. And even before people could go on stage, like, oh yeah, I have this thought in my, maybe we could do this. And I like that. Very strong engagement. So again, thank you for the 3 E's, as I said, the importance of early detection, really following the science and the evidence, and keep the energy going. So on behalf of the Roche Diagnostics team here in India and Asia Pacific, thank you for being here. And we hope that you can really take this forward. So the next time we're here, we're discussing not why we should be doing it, but really what you've been doing and more case studies on how it's helped people. Yeah. Thank you very much. Have a good evening. Can I also invite everyone to come for a group photo? Okay.
Request everyone to kindly come for the group photo. Yeah. Please.
Switch off. Long place. Last line. Just direct it.
We would like to